So if you're
Okay,
ready, can I start the timer?
yes, please.
Yes. So timer I have started, and here is the question. Right, so if you've read and understood, kindly tell me. Considering it to be a critical care patient, how would you manage him?
Yeah, ma'am. I would like to manage this patient according to the PRIS protocol, and
Yes.
first giving attention to the ABCE. I will ask my assistants to attach the patient towards the hemodynamic monitor and the pulse oximeter. At first, I will look for the airway. If the patient is talking, I'll go for further stage. But if the patient is not talking, like unconscious, I would like to go for an intubation by calling to the anesthetist and start high flow humidified oxygen therapy for this patient. I'll keep the patient propped up position. After maintaining airway, I'd go for the ventilation. If the oxygen saturation is in normal level and the respiratory wall is moving bilaterally symmetrical, and there is no evidence of hyperresonance or dullness, any abnormal bed sound, I would look for the circulation. Then for the circulation, actually, I would first look for the underlying cause. Here, the
Very
scenarios,
good. Yes.
their underlying
Yes.
cause, and here, according to the scenario, patient is suffering from some kind of respiratory depression, maybe secondary to morphine toxicity.
Yes.
Then for this, I'd like to give the patient the morphine antidote, Naloxone, at first 0.4 to 2 milligram IV stat, and repeated every 2 to 3 minutes until a dose of 10 milligram total. And I would simultaneously look for the side effects of Naloxone if the patient is having.
What are the side effects of Naloxone? How would you know that you've given the overdose to the patient?
Yeah. For us, the side effects of Naloxone, it may be sweating, tachycardia. It may also can lead to cardiac arrest, abdominal cramp, and abdominal pain, and also it may lead to pulmonary edema. If there is any new appearance of respiratory basal crepitation or not, I'll check for that.
Where would you ideally manage this patient, and who would you involve in
I'd
the
like
management?
Yes, I would like to manage this patient in the ITU, and I would like to involve a respiratory physician, operating consultant, anesthetist, and critical care team.
All right, okay. If just suppose you've done ABG of this patient, how would that, how do you expect that to be?
Due to the effect of morphine and the respiratory depression, patient may have respiratory acidosis according to the ABG.
Yeah, okay. Sorry, what did you say?
Patient may have respiratory acidosis due to respiratory
okay.
Yeah.
All right. Can you tell me what type of respiratory depression this patient has?
As there is respiratory depression, patient may have type 2 respiratory failure, including hypercapnia and hypoxia.
All right. How many types of respiratory failures are there? And what is the difference?
Yeah, actually, there are two.
Yes.
Yeah. There are actually two types of respiratory failure, type 1 and type 2. Type 1, mainly the respiratory failure due to a mismatch in the ventilation and perfusion ratio, like the amount of air that is going in and out of the lung that cannot be matched with the perfusion. The perfused blood cannot be oxygenated. It may be due to any lung pathology like pneumothorax, any pneumonia, or any kind of any kind of lung pathology like carcinoma. And the type 2 respiratory failure is actually due to where the amount of carbon dioxide that is built on our body that cannot be eliminated. That can be due to increased airway resistance. Yeah.
Yes. Can you tell me the mechanism how morphine causes respiratory depression?
Yeah, actually there are morphine receptor like mu receptor that is located in the respiratory center, and morphine will increased morphine that cannot be metabolized or overdose that will act on that receptor, and that will cause the respiratory depression.
All right. Okay. All right. Right. Can you tell me, once there is respiratory depression, how body will
Yeah.
cope to neutralize or to bring it to buffer the body back into the normal? Which organs will
Okay.
play
If there is
major
any
role? Yes,
i-
in this case.
Yes, if there is any respiratory, yeah, in this case, if there is any respiratory depression, there will be carbon dioxide buildup in the body, and
Yes.
that will readily cross the blood-brain barrier, yeah, and enter the CSF. And in the CSF, that will convert it to with water, it will convert it to carbonic acid, and carbonic acid then convert it to bicarbonate and hydrogen ion. And
Yes.
hydrogen ion will increase the central chemoreceptor located on the ventral surface of the medulla surrounded by the CSF, and that will increase the respiratory rate, and the body will try to hyperventilate to eliminate the carbon dioxide in the body.
In how many days kidneys will start functioning and they'll start compensating?
Yeah, actually the kidney is acid content in the blood in 3 to 5 days, ma'am.
Okay. Yes. After 3.
Yeah.
All right. Okay. How do kidneys regulate acid-base balance? Can you explain?
Yeah, yes, ma'am. The kidney actually regulates the acid-base balance by eliminating excess amount of acid in our blood in the form of hydrogen ion in the proximal tubule, and whenever there is acidosis, it will also decreases the excretion of bicarbonate so that it can be compensated.
Okay. Can you tell me the definition of chloride shift?
Yes, actually, whenever the carbon dioxide is mixed with the blood, and a major amount of carbon dioxide is by water, that will cause the formation of carbonic acid, and that will by the help of the enzyme carbonic anhydrase, and that will be again dissolve it to hydrogen ion and the bicarbonate ion, and this bicarbonate ion will be, and this will occur in the RBC. So this bicarbonate ion will go out of the RBC into the plasma in exchange of chloride ion, so that the electrochemical neutrality can be established, and they can remain the same. And this mechanism of chloride shifting is called chloride shift actually.
Can you tell me how the carbon dioxide is transported in the blood?
Yes, the majority of the carbon dioxide is actually transported. We have as the bicarbonate ions, and like 70%, and 20% will be transmitted as the carbamino hemoglobin, like the carbon dioxide will bind to the globin portion of the hemoglobin, that will cause the formation of carbamino hemoglobin, and 10% will be transfused in the dissolved form.
How many types, this morphine acts on which receptors, and how many types of those receptors are there?
Actually, this morphine acts only the central nervous system at the respiratory center, but there are 2 types of receptor, that is peripheral chemoreceptor and the central chemoreceptor. The peripheral chemoreceptor is located in the carotid sinus, that is located at the bifurcation of the common carotid artery at the level
Yes.
of the upper body of the thyroid cartilage, and it is innervated by the glossopin nerve, and the chemoreceptor is located central nervous system just in the medulla, in the ventral surface of the medulla, which is surrounded by the CS.
Very good. Okay, in this patient, the response is, if patient still
Hello?
has hypercarbia. Hello, can you hear me? Hello? Yes. Can you tell me in this, yes,
Please,
my
can you please
network
repeat
is,
the question?
yes, my network is very bad. Can you please tell me in
Hello?
this patient,
Okay, she got disconnected.
She got disconnected. Okay.
Sorry, I got disconnected. Yes,
No,
I was
ma'am, it's
asking
okay.
you.
Yeah,
My network is
yeah,
very bad. Yes, I was
yeah.
asking you. In this case, patient presents with hypercarbia, but then
Yeah.
how does the body regulates it, or what is the mechanism behind hypercarbia?
Yes, ma'am. It's like I have said earlier also, like whenever there is increased carbon dioxide buildup in the body, that will be transmitted through the bloodstream towards the CSF as it crosses the blood-brain barrier, and it will cause central acidosis. And this central acidosis will stimulate the respiratory center, and the patient will try to hyperventilate to compensate or to eliminate excess carbon dioxide in the body. But the fact is, if the cause is not resolved, if the carbon dioxide buildup cause is not resolved, patient will hyperventilate up to a level. And whenever the patient becomes fatigued, then the alveolar ventilation will be decreased, and it will cause further respiratory failure, type 2 respiratory failure, and ultimately patient may be expired.
So if you have to ventilate this patient, how would you determine what levels or what you have to keep the patient on?
Sorry,
How
ma'am.
would you
I couldn't
determine that what level of ventilation support you are going to give to the patient?
Like for this patient, after intubating this patient, my target would be to maintain the oxygen and carbon dioxide, partial pressure of oxygen and carbon dioxide towards the normal level, ma'am, so that
Normal range,
the
yes.
respiratory, yes, ma'am, respiratory acidosis and all the metabolic abnormalities can be corrected.
Yes,
Like
very
the
good.
partial pressure of oxygen 10 to 13 kilopascal, and partial pressure of carbon dioxide is 4.5 to 6 kilopascal.
Yes, very good. Okay, I'm done.
Yeah.
Yes.
Thank you, ma'am.
Thank you so much. Yes, please, feedback. It was excellent, even though I got disconnected in the middle, but yeah. What is
No,
this Rafiq
this got
family?
disconnected at the last, actually, ma'am.
Yeah, bell went, but I'm asking slow, I'm tired. So
Yeah.
questions, yeah. Yes, please give feedback.
Thank you,
Good.
everyone.
Ask questions. Dr. Ishwak, don't say just great. Ask him questions. Bombard him with questions.
Yes, covered almost everything. I don't know.
Yes, he covered everything. I'm just joking.
Ask him.
Yes. I asked
Criteria
him
for
every
ITU
question.
admission, maybe.
Dr. Abhishek, one sincere advice. If examiner asks you same question 100 times, never say I answered it before as well.
Oh, sorry, ma'am.
That's
Sorry.
okay. No, because with me,
ma'am. I thought that you couldn't understand. Sorry, ma'am.
no, I asked you, but I asked you again.
Yeah, I know
But
that.
then, like in exam, if it becomes habit with me, like you might say it in front of them as well. So there you have to be careful, not to make it a habit.
No, I'll never do that, ma'am. Trust me. It's just I thought that you couldn't hear that.
My
This
network is
network,
bad.
ma'am. I'm so sorry.
Yes, that's all
Sorry.
right. No,
Yeah,
that's
that's
okay.
why I could.
My network
Yeah,
is bad. I'm just guessing who is saying what. But still,
Okay.
I logged in early because 2 days gap, and then. Yes, Dr. Abhishek, from where did you read, please?
Yeah, Dr. Benish, actually the respiratory centers and all the innervation, you will get that from the, Part A notes, MRCS Part A notes. Okay, that will be great. Like all the details are there, but you just know where the peripheral and central chemoreceptor and what stimulates that. Like in case of central chemoreceptor, it will only be stimulated by the concentration of hydrogen ion. Whenever carbon dioxide will just cross the blood-brain barrier, it will cause increased formation of hydrogen ion by the mechanism I have said earlier. So this central
He
acidosis
said
will
it
stimulate.
again. I've said it earlier.
Okay.
This will become your habit, then it may cause.
No. I'll never ever say that. I promise, ma'am. Then the peripheral chemoreceptor in the carotid sinus, innervated by glossopharyngeal nerve, it will be stimulated by three things, like also the pH of the blood, and then decrease it decrease hypoxia and hypercarbia. These three things.
Dr. Abhishek, you said glossopharyngeal now.
Yeah.
Is it in the glossopharyngeal?
Yes, carotid sinus and
Are you
carotid
sure?
body supplied by
Yes,
glossopharyngeal.
yes, I think so as well.
Okay.
Yeah, yeah,
Okay,
and
supplied with glossopharyngeal.
glossopharyngeal.
Okay.
Yeah, and another one in the aortic arch, the baroreceptor, that will be by vagus.
Yes,
That's
yes,
right.
he's right.
Can you please, Dr. Abhishek, can you please highlight some few causes of type 1 and type 2 respiratory failure, if you can?
He told.
Yeah, for type 1 respiratory failure, the cause mainly pathology in the lung. That would be like pneumonia, bronchitis, pneumothorax, hemothorax, this kind of lung pathology. And in case of type 2 respiratory failure, there will be pathology in the other area other than lungs, actually, like the obstructive airway diseases like asthma, COPD, and any kind of upper and lower airway obstruction, then any kind of respiratory depression due to central nervous system like drugs and like some kind of stroke or any, then we can also go for like the a mechanical abnormalities like kyphus, scoliosis, decreased respiratory movement, that will just lead to the type 2 respiratory failure.
Perfect, yes.
Yeah, thank you.
In atelectasis, Dr. Abhishek, from where we get type 1 or type 2? Atelectasis type
In
1?
atelectasis, a type 1 respiratory failure.
Yes.
Basal atelectasis, yes. ARDS, type 1 respiratory failure.
Okay, moving on. Yes?
Yeah,